My name is Emmeline Lee. I'm a radiologist from Perth, Western Australia, and I'd like to thank Radiopedia for the opportunity to speak today. I'm going to be speaking about subfertility. I know that is not an issue that you encounter on a day-to-day basis in the hospital. However, you will see this if you do any reporting at all for the community because it is an increasing clinical issue worldwide. In fact, 1 in 9 pregnancies in Australia are now conceived using some sort of help from our gynecological colleagues. And all of these ladies need imaging, which is integral to the investigation of subfertility.
These are my disclosures. A couple of definitions to begin with. So infertility is the inability to conceive despite regular, unprotected sexual intercourse for a year, whilst the definition for subfertility is a little bit more flexible in that it's really any form of reduced fertility with prolonged time of unwanted non-conception. I'm going to start and end with this slide because as radiologists, what we have to produce are good reports that your clinicians want to read. And essentially, it's really what they want to know and they need answers to their questions. So if a gynecologist sends a lady to you for a scan to investigate fertility, what they really want you to exclude would be problems with the uterus, including Mullerian duct abnormalities. They want to know about the endometrial thickness and homogeneity and whether that is appropriate for the time of the cycle. They want to know whether the cavity is okay, whether there are any intracavitary lesions, including polyps and fibroids. They want to know whether there's evidence of endometriosis. They want to look at the ovaries, and in particular, they want to exclude PCOM, and also they want you to exclude hydrosalpinx. Why is imaging so important? Because we need to cover all of the lesions that we talked about on the previous slide and more. So what we can do is we can aid your gynecologist in making decisions regarding therapy, and also sometimes as radiologists we can actually provide the therapy itself. So in this lecture, I'm going to touch on a few things. We're going to spend most of our time talking about ultrasound, but we're going to chat a bit about hysterosalpingograms and hycoses and touch on saline infusion sonograms, MRIs, and at the end, a little bit about therapeutics. So the mainstay of investigations for subfertility is transvaginal ultrasound. You should start off with a transabdominal ultrasound because that gives you a broad overview of what is going on. Sometimes some lesions are better seen transabdominally, such as big fibroids. However, I would consider a transabdominal ultrasound by itself not good enough for the investigation of fertility. You really do need to go on to a vaginal scan, and that should be a high frequency probe, and you should be able to produce a good quality 3D coronal or VCI plane, primarily to look at the external contour of the uterus. And whilst you are doing your vaginal scan, you should be assessing for tenderness and mobility of all the organs, because that's really acting as another hand and acting as a part of clinical examination in a way. You need to report on that as well. We're going to start systematically and talk about the uterus first. We're going to begin talking about structural Mullerian duct abnormalities. I'm going to be controversial to begin with by telling you that there is no fully accepted classification system for structural Mullerian duct abnormalities, and it comes down to a battle of two superpowers. It's the American system versus the European system. They are actually very similar, but the main point of difference between the Europeans And the Americans is that the American system includes an arcuate uterus, whereas the European system does not. In Australia, the American system is mostly the one that is used, and that is the one that I'm going to concentrate on today. So there's no right or wrong classification system to use. I just think you need to pick one that you are familiar with, that you can use consistently, one that your referrer likes. So it would be really good to confer with your colleagues to ask them which system they would like and use that system. So your main role as a radiologist reporting subfertility scans would be to decide, first and foremost, is there actually a significant structural Mullerian duct abnormality? So you need to look at the internal contour and decide, is there a significant dip or not? And if there isn't, well, it's going to be normal. Otherwise, if you decide that there is a problem with the internal contour, you then need to look at the external contour and report, is there a fundal cleft? And the main things to report would be to look at the internal midline septation. You want to look at the interosteal distance between the two ostia, and you need to report the wall thickness, which is the line from the top of the fundus to the interosteal line, because these are the lines that will help your gynecologist decide whether to operate or not. On a day-to-day basis, the main issue that most radiologists face when there is a significant internal cavity issue is to decide whether the uterus is a bicornuate type uterus or whether it's a septate type uterus. And in order to separate these two, you need to look at the external contour and decide whether there is a significant fundal cleft. And by significant, most people would say anything over 1 centimeter would be significant. So if it's shaped like a heart in that there is a significant external contour as well as a significant internal contour problem, you're dealing with a bicornuate uterus. Whereas if there is no significant fundal clefting on the outside of the uterus, but there is internally, you're then dealing with a septate type uterus, which is by far the most common. Whilst both septate and bicornuate uteruses are associated with problems with either falling pregnant or once there is a conception, there sometimes is problems with the baby itself. They are managed completely differently, and this is why it's really the radiologist's responsibility to report this accurately, because it really helps your clinicians make decisions about what to do. Because if you report a septate uterus, they may contemplate surgery, whereas if you report a bicornuate uterus where there is a fundal cleft, no surgery can be performed. 3D ultrasound is really good at distinguishing between the two if it's a good quality ultrasound, and sometimes saline infusion might also help. But if you have any doubt, definitely refer the patient for an MRI scan. In terms of when uterine septations become relevant, there are lots of publications and lots of different opinions, and lots of people do different things. However, most people would agree that unless a septation was over 15 millimeters, generally speaking, people would not operate. So I guess I've put this slide up here just to show you the different lines which we talked about earlier. So once again, talking about the interosteal distance, talking about the internal midline septation, talking about wall thickness. They're the lines that you should be reporting as a radiologist to help your clinicians make decisions about therapeutics and surgery. I'm going to start talking now about the different Mullerian duct abnormalities. So the class 1 defects are the ones where there is complete agenesis or hypoplasia of the uterus. Most of these ladies know about it really early on because they present with primary amenorrhea. So when you scan them, you cannot see anything. No uterus because it has failed to form. Now, the class 2 uteruses are the unicornuate uterus. So the uterus is a single cavity. So it really looks a bit like a sausage, to be honest. It doesn't look like the normal shaped uterus, and that is due to a failure of formation of one side. And you may have a little remnant bit, and that is a unicornuate with a remnant horn. That's a bit that you should also look for if you see a unicornuate uterus. And this is what I mean about a sausage shape uterus. So you really have just that one cavity, and it's usually pretty obvious on 3D ultrasounds. It can be quite tricky on 2D ultrasounds because sometimes, as you know, the uterus can, sit in a different position. So you do have to make sure you do good sweeps through the uterus and be confident that this is what you're looking at. It's usually pretty obvious on HSG, and if you do see only a cavity that's just the one side, you might want to go back and look at your speculum examination again to make sure that there is indeed only one cervix. Moving on to the class 3 and class 4 defects. Here, they're due to a failure of fusion. So what you will see is in these two entities, you will see a significant fundal cleft. So the external contour is really dipped. And here we're talking about the didelphys uterus and the bicornuate uterus. The difference between the two is really that with the didelphys, it's really widely spread. There's a very deep clefting, and there's usually two cervices, whereas with the bicornuate uterus, there is a significant cleft externally and a significant internal clefting, but there's usually only one cervix. So here's an example of a didelphys uterus, and you can see how widely spread it is, plus you can see the external cleft, as opposed to a bicornuate uterus where you do see the external cleft, but only one cervix because they're joined in the midline. Moving on to class 5 and class 6 defects. Here it's due to a failure of resorption. So what you get is externally you have an intact fundus, but internally you will have a spectrum of issues to do with how much clefting there is. So I mentioned before that a septate uterus is way more common than a bicornuate uterus. And what you need to do is make sure you report the length and thickness of the septum, remembering that there is no external fundal clefting with a septate uterus. Here's a really good example of a complete septate uterus with an intact fundus at the top, but internally you see two separate cavities and indeed two cervices. And when my colleague actually did a speculum examination and saw that there were two cervices, he then put catheters into both cervices and contrast through both tubes. And we spoke a little bit before about how the European classification does not include an arcuate uterus. Once again, that is an extremely controversial topic. The Americans definitely classify it, and there are lots of papers that talk about how it is fairly controversial and does it impact on clinical practice. Yes, it does, because if you don't report an arcuate uterus as per the European system, you actually will find that you're going to be reporting more subseptate and septate uteruses. As to the subtle difference between a subseptate and an arcuate uterus, it probably doesn't matter clinically because most gynecologists would not operate on these anyway. 3D ultrasound is pretty good, but once again, I will say to you that if you are not sure, it's best to get an MRI scan. A couple of other little practice points regarding structural Mullerian duct abnormalities. Remember that with IUDs, you can get pregnant if they're not put into both horns in a true bicornuate or true septate uterus. So you can see pregnancies in one horn if you have only a single IUD. Remember that with the blind or rudimentary horns that are associated with unicornuate uteruses, that they may cause significant pain and may actually need surgical management. And I had a really interesting case a couple of years ago. I work in a tertiary hospital, and a lady came in with right iliac fossa pain, and it was thought that she had acute appendicitis. And when they actually operated on her, they found that her pain was due to blood within a blind horn and that she had an undiagnosed unicornuate uterus. Remember also that if you have a significant structural Mullerian duct abnormality, that there is an association with renal tract anomalies, so you should also be scanning the kidneys as well. In terms of practicalities, I found a really good article which was produced by a group out of Melbourne, which gives a really excellent overview and good practical advice as to how to classify Mullerian duct abnormalities. So I appreciate that this is a crazy busy slide, but I'm hoping that I will be able to summarize it for you. So if you're reporting these, you need to look at the 3D reconstruction of your uterus and go, is it a normal shape or is it a sausage type shape? In which case you're talking about a unicornuate uterus, and go down that route. If it's looking fairly much like a normal shaped uterus, you need to look at the external contour and decide whether the cleft is greater than 1 centimeter. If there is significant clefting externally, then you have to decide whether it's a didelphys or bicornuate uterus. If there is no external clefting externally, then you look at the internal indentation and you do your measurements. And if it's less than a centimeter, you can consider that normal. If it's between 1 and 1.5 centimeters, that's considered arcuate. And if it's greater than 1.5 centimeters, then you're talking about a septate type uterus, and that's when it becomes important for your gynecologist. Moving on to the endometrium now, we're going to talk about how to report these. So I would encourage you, when you report a pelvic ultrasound, not just for fertility, but for everything, you need to relate this to the day of the cycle, because the endometrium totally changes according to whether a lady has ovulated or not. So you need to report the day and length of the cycle so that your gynecologist knows when the ultrasound was taken and whether the thickness of the endometrium is appropriate for that day of the cycle. You need to also make a remark about the homogeneity and the vascularity of your endometrium. The gynecologist is most interested in whether there is a problem within the cavity, because if there is, this can relate to recurrent implantation failures and recurrent miscarriages. And when I talk about intracavitary lesions, I am essentially talking about polyps and fibroids. You all know what an endometrial polyp looks like on ultrasound, so you know that it's usually echogenic and that there's usually a beautiful feeder vessel with a characteristic vascular stalk. That is pathognomonic of an endometrial polyp. These are best seen in the first half of the cycle, in the proliferative phase, when the endometrium is thin and hypoechoic. Intracavitary lesions can also comprise of fibroids, which look quite different to polyps. So these are usually hypoechoic and they usually have some vascularity, but usually not a characteristic feeder stalk. These are best seen actually in the secretory phase, which is when the endometrium is echogenic, and so the fibroids actually really stand out at that time. If you do see a fibroid, your gynecologist wants to know whether there is distortion of the cavity and whether the fibroids are sitting within the cavity. Here's a nice example of a intracavitary and submucosal fibroid. If you're not sure, a saline infusion sonogram may be quite useful in helping delineate how much cavity involvement there is, and this can help your gynecologist make decisions about operating or not. Don't forget to talk about other fibroids and adenomyosis as well. They need to know this, although these don't tend to impact on fertility. I do want to spend a little bit of time talking about fibroids because they're very common and they are a great source of confusion for some. I think most of you are now aware that there is a FIGO classification of fibroids, which is increasingly being used by radiologists and clinicians around the world. So this classification system is so great because it is actually very easy and it lends consistency to reporting. So I think the ones that are most important for fertility would be the types 0, 1, and 2, which are the submucosal and intracavitary ones. They are the ones that the gynecologist usually would operate on if they think that a lady has problems with fertility. Now, the types 3, 4, and 5 are the most common types that you will encounter in daily practice. They're the intramural ones. It's just really good to describe them, but usually they don't impact fertility. Type 6 and 7, which are the subserosal ones, don't impact on fertility either, but it's really important to distinguish the pedunculated ones, the type 7s ones, from the solid ovarian lesions. And this is why I'm mentioning this today, not because of its impact on fertility, but because I think a lot of people get confused between these and the solid ovarian lesions. So make sure if you see this, that you are looking to see that you can see an ovary separate to it. That would be the most important. Moving on to ovaries now. We're going to chat about antral follicle counts. We're going to chat about polycystic ovaries and endometriomas. But before we do that, I want to emphasize a really important practice point when you are reporting for fertility specialists, which is, are the ovaries accessible when they do their transvaginal ovarian harvesting? Because sometimes you might find that your ovaries are stuck down posterior to the uterus, or it might be posterior to bowel. Now, in that instance, you will find that those ovaries will not be accessible. And it's really important to report these because your fertility specialist does not want to get any surprises on the day of the egg retrieval. I also mentioned before that when you are looking at ovaries, that you should be talking and reporting about their mobility and tenderness, because if there is decreased mobility and lots of tenderness when you're scanning vaginally, that might be a good sign that there are problems with endometriosis. A little bit about antral follicle count to start off with. So gynecologists use these to determine fertility potential and to plan IVF protocol. So usually now people are using AMH, which is a blood test, as a marker for ovarian reserve, but they still rely on us to report antral follicle counts because it is important to determine the dose of their fertility drugs. So make sure that there is good and accurate counting, and this should be done on vaginal scans only. It's not very accurate if you're doing the count transabdominally. Now, I want to spend a bit of time talking about the very common condition of polycystic ovaries. I think there's quite a bit of confusion amongst the radiology community as well as in the general community about the difference between PCOM and PCOS. I want to direct your attention to this article. It's actually an international evidence-based guideline which is published in 2018 for the diagnosis of PCOS, and it was a multidisciplinary team that published 200 odd pages about polycystic ovarian syndrome, of which one page is to do with PCOM, which is polycystic ovarian morphology, which is what radiologists have to report on. I've summarized this page for you, and it's essentially how do we diagnose PCOM? And this is if you see 20 or more antral follicles, that is, this tiny little follicles between 2 and 9 millimeters, and or greater than 10 cc's in volume. But if you're going to use the volume measurement, they want you to exclude the large cysts and corpus luteum from that volume measurement. One of the practice points is they would not want you to make the diagnosis of PCOM if a lady is less than 8 years post-menarche. The reason is that in adolescence, whilst their cycles are starting to settle into a pattern, you can get lots of follicles, or what I would describe as multifollicular ovaries. Do not call this PCOM if you have a teenager who's less than 8 years post-menarche. They say in the document that a transvaginal scan is much better than a transabdominal scan in making your diagnosis, and particularly in the counting of follicles. There is a say in the document that you should be reporting which approach you use, whether it's TA or TV. They would encourage you to report your ovarian size in 3 dimensions in millimeters and the volume in mils. They want you to report the follicle number per ovary, and don't forget as well as they want you to report the endometrial thickness and appearances. So I mentioned before the very important difference between PCOM, which is polycystic ovarian morphology, versus PCOS, which is the syndrome. And us as radiologists, we are in the business of diagnosing PCOM, which is an ultrasound diagnosis of greater than 20 antral follicles or greater than 10 cc's in volume. That supersedes the Rotterdam criteria. And you should be using the international consensus criteria, which is what we've just talked about. PCOS, on the other hand, is an issue which the clinicians usually diagnose. It needs 2 out of the 3 positive criteria. You either diagnose that on clinical grounds, biochemical grounds, or ultrasound grounds, but it needs 2 out of the 3 of these to be positive before a lady is labeled with PCOS. So really, we are not really in the business of diagnosing PCOS. It's PCOM that we are responsible for. Moving on to endometriomas and endometriosis now. You all know what a classic endometrioma looks like, which is the cyst, which is filled with fine internal echoes that looks like ground glass. Remember, don't call these solid because they're not solid, because if you cut through them, it is blood. So you can tell the difference between this and a solid issue because there is no vascularity in these, and there is posterior acoustic enhancement. Sometimes they have echoes within them, and these just represent acute bleeds into an endometrioma. Remember that how you differentiate these from a hemorrhagic cyst would be to ask for old imaging, and if it's persistent, it has to be an endometrioma rather than an acute hemorrhagic cyst. If you don't have old imaging, bring the lady back in a few weeks to confirm that it's still there. Moving on to the tubes now. So your main thing to exclude on scanning for subfertility would be hydrosalpinx, which is a fluid-filled tubular structure, and it can be quite large. And the pathognomonic thing would be the presence of incomplete septations, and sometimes if you turn on it, you might get what they describe as pearls on a string. Now, obviously, a blocked fallopian tube might manifest as a hydrosalpinx, but sometimes we don't see that until we do a HSG or hycosi. More on that later. Moving on to the adnexa now. Essentially, here I'd like to just raise the issue of deep infiltrating endometriosis, or DIE, and here you are actually beyond, the ovaries, you are beyond the tubes, you are looking to see whether you see nodularities, you're looking to see whether there are any nodules against the pelvic side wall or along the uterosacral ligaments, or sometimes you might see it on bowel as well. Don't forget to talk about the pouch of Douglas when you're actually doing your subfertility scans. Essentially, you're looking for free fluid and you're looking for hemorrhage within that, because that might be a sign of DIE or endometriosis. You also want to make sure that the pouch of Douglas is not obliterated, because if it is, you might want to think about endometriosis. Moving on to diagnostic procedures now, radiologists play a really, really important role in establishing tubal patency, either with the HSG or hycosi. Sometimes we're asked to interrogate the cavity, and we do that using saline infusion sonography, and that's primarily to look at intracavitary fibroids and polyps. So a HSG has been around for a long time now. You all know that when we do the HSG, you also not only just do this for tubes, but you might want to look at the cavity as well and describe it. And also it's a really good test to look at the internal contour, so you can exclude major structural Mullerian duct abnormality this way. I'm just going to show you a hycosi now. Some of you may not have seen this before, so look at the echogenic tube on the right, and you can see now the contrast moving to the left, and you can follow the tube all the way around to near the ovary, and now you might start to see spillage of contrast. Moving on to saline infusion sonography. So just a short clip of a saline infusion sonogram. So saline is hypoechoic on ultrasound, and you can see the little polyp that's sitting on the posterior wall. So in this way, by outlining the cavity, you can see intracavitary lesions really well, and you can see a little polyp that's sitting in the posterior wall here. Moving on to therapeutics now, most people will know that HSG or hycosi is not only diagnostic, it can be therapeutic as well, in that about 30 to 40% of women who are subfertile who have a hycosi or HSG will get pregnant naturally in the first 6 months following this. And I'd like to talk about a few other therapeutic procedures that radiologists are increasingly getting involved in. I think lots of people are now aware that Lepardol flushing is now endorsed by multiple colleges around the world as being superior to HSG and hycosis for the therapeutics in the subfertile woman. Traditionally, that's been fluoroscopically guided, but people have started doing this using ultrasound guidance. I think if you are going to be doing this, make sure that you are aware of the safety issues, make sure you use imaging guidance, and to make sure that you are looking for intravasation, and to stop if you see intravasation. You also want to make sure that the lady's thyroid function is good both before and after your Lepardol flushing. Some of our interventional colleagues have started doing cannulation of blocked tubes. It's a fast and easy procedure most of the time, and it can make a world of difference. Some of our colleagues are also using MR-guided high-intensity focused ultrasound ablation of fibroids, and that's been very successful. I just will say a little note here in that if a lady is planning pregnancy, that they should be avoiding uterine artery embolization because that's associated with some bad outcomes. So we've come back to the slide we started with, which is what gynecologists want to know, and I hope we have covered all of this today. In terms of what to take home from this lecture, I hope you remember to include the day of the cycle and the cycle length. That is of fundamental importance in all your gynae scans. I'm sure you will all be doing good quality TV scans with good quality 3D coronal views. Don't forget to report systematically from the uterus, looking at the external contour and the internal cavity shape, and to exclude intracavitary lesions. You want to look at the ovaries, primarily to exclude PCO and endometriomas, but don't forget to make a comment as to whether they are accessible for your fertility specialists. Don't forget to look at the nexa for signs of endometriosis and to exclude hydrosalpinx. And remember that radiologists are increasingly important now in therapeutic options for subfertile women.
If you have any questions or comments, please email me or in fact connect with me on LinkedIn. I'd be very happy to see you on that platform. All the best and thanks so much for listening.